We welcome you to the next episode in the conversation series. As some of you might know, there's a series of webinars that we have been running, and this is a continuation of that, and it'll go on, and we will keep updating you with new and exciting topics every Saturday. A few admin details. Everyone is on mute, and let's stay on mute while the speakers are speaking. And we will, of course, have an opportunity to discuss and ask questions and comment on what they're saying. So while the speakers are speaking, as questions strike you, please type them in the chat box, and me and my colleagues are reading the chat box as we go along, and we will try and answer as many questions as we can. Or if you want to actually speak out your question, then raise hand, and we will look at the raised hands again at the end of the conversation, and ask you to come in and ask your question verbally. A raise hand feature, as you would know, is if you look at the participants panel on the right, if you open the participants panel, you will be able to choose raise hand option, and your hand will be shown as raised. Okay, so with that bit of admin, welcome to the conversation series. We have been running these series on various topics which are broadly of interest to the management education community, that is students, prospective students, faculty members, researchers in the area of, broadly in the area of management studies, and also relevant to a wider audience beyond management, especially in areas like economics and public policy. So it's relevant for all these communities. We have, over the last few weeks, some of you might have attended, and we discussed topics from management education in these uncertain times, to digital disruption, to climate change, to corporate governance, to supply chains, and new supply chains needed for the new world, and so on. And there are many more titles and topics in the pipeline in the coming few weeks, and we'll keep coming back to you with those. So stay tuned to all the channels where you heard about this, and you will hear about more. So with that, let's come to today's topic. Today we are tackling probably one of the most relevant topics in these times, healthcare. Healthcare is on top of everyone's mind these days for obvious reasons. In India, most of the healthcare debate has been focused around public health, about government, about funding, about provision of healthcare by the government, as if all healthcare was delivered by the government. But as you saw in your own poll question, most of you believe that much of the healthcare spending happens in the private sector by people from their own pockets. So that consumer level healthcare has not been a matter of much discussion. Because a large amount of healthcare happens at primary care, individual consumer level, we will spend some time today looking at how that provision can be improved through health systems design. The discussion is long overdue. It is not just triggered by COVID-19. This discussion about healthcare at the ground level should have happened years ago. So we are trying to make that discussion become live in this next hour or so. Um, the pandemic, of course, has made that much more important and much more urgent, but that topic is of relevance in the long term, not just during the crisis. And our eminent speakers today, and I'll introduce them to you in a moment, will be talking about developing a health systems design strategy for India, both from the consumer choice angle as well as from the development angle. The focus will be to see if consumer choice and service marketing in the context of primary healthcare can take. I have two really eminent speakers on hand today. So this will be a conversation between Dr. Nachiket Moore, who's a visiting scientist at the Banyan Academy of Leadership in Mental Health near Chennai in Tamil Nadu. and our very own Professor Darshini Mahadevia, who's a professor at the School of Arts and Sciences at Ahmedabad University. Dr. Nachiket Moore has so many credentials and achievements that itself could become the subject matter of another webinar, but we'll try to compress that. Dr. Moore has a PhD in economics from the University of Pennsylvania. His current work is principally focused on design of national and regional health systems. He has been a member of the Planning Commission's high-level expert group on universal healthcare. He has been a member of the Primary Care Task Force of the Ministry of Health and Family Welfare, the Health Commission for the state of Himachal Pradesh, the Standing Committee on Health System Strengthening at the National Academy of Medicine in Washington, D.C., and so on. This is a short list of the various eminent forums that he has worked with. Dr. Moore helped create a new model for comprehensive primary care, and that is pioneered by a body called Suga Vajavu Healthcare in remote parts of rural Tamil Nadu. And he also offers a seminar on health systems design at the Banyan Academy of Leadership in Mental Health. So that was quite a compressed version of a very elaborate profile of our eminent speaker, Dr. Moore. Dr. Moore will come to this discussion from a health systems design angle, because that's where his focus on designing health systems. Professor Darshini Mahadevia works with us at the School of Arts and Sciences. She's a professor at our School of Arts and Sciences, as well as a program chair for our BA Honors program. She has a PhD from Jawaharlal Nehru University and a master's in urban and regional planning from the School of Planning and Architecture in New Delhi. Before joining Ahmedabad University, Darshini was at the Faculty of Planning in Sept University, where she held the position of Dean, as well as Director of Center of Urban Equity that she herself established there in 2009. Professor Mahadevia comes to this discussion from the public policy angle. She has co-authored the Gujarat Human Development Report, so that makes her eminently qualified to talk about this from a human development angle. In recent years, her interests have included many things, including impact of increasing temperatures on Indian cities due to climate change. And she is currently working on looking at the outbreak of COVID-19 and researching the geographies of the spread of this virus. Okay, so that was quite a mouthful. To try and introduce these two very eminent researchers and scholars in 5 minutes was no mean task. Having said that, enough of me. You are not here to listen to me. You're here to listen to the experts. So I'll get out of the way now and hand you over to the real experts. So Professor Mahadevia, would you take it on from here?
Yes, sure. Can you hear me?
Yes, yeah, we can.
Okay, so today's topic, as Ravi said, is well suited to the period that we are in. But it's not just pandemic in India. We've been hearing a lot about what do we do with our health systems, given that it's not serving, and in pandemic we have seen it's neither serving the rich and certainly not serving the poor. In human history, we've seen many pandemics, and I think some of the information now is coming up. It's been captured in images, in the literary writings, etc. I come from a discipline which is actually dealing with, which is urban planning, which is dealing with the preventive side of the any pandemic, and it's a baby of plague pandemic, so to say. Now, there have been sort of stories about COVID-19 pandemic, if we come to the current, in terms of inadequate or even bordering on disastrous response to COVID-19 pandemic. And we hear a lot of very sad stories, but we also hear stories of human fortitude. and also about dedication of service among healthcare providers. But the question that is there in our mind is that do we, and does a system in response to such pandemic and with so much of long history of experiences of pandemic depend upon human individual fortitudes or dedication to deal with such a pandemic? And so it's a chance that we get a good healthcare provider. Can we take a chance that some individual will rise up to the occasion in such pandemics, or do we think in a systems way? Can we have more? Are we going to depend on Florence Nightingale's stories or our own sister Catherine Christian, who lost her life at Civil Hospital about 2 weeks back? And so the answer to that is that we need to think beyond rising above individual efforts to look at the situation that we are in and deal with health issues in a more sort of systemic way. Although I come from into the discussion from a development perspective, and we've been familiar in the discussion in human development areas that we've been discussing whether, and it's a question that was posed the first, second question, whether we should be focusing on the public or we should be focusing on the private. Or I think Dr. Moore has written quite a bit on community-based healthcare provisioning, and that some of the systems in Gujarat we have seen has worked in certain contexts, but probably they've also become a bit dysfunctional in the recent year. We also know that 85% of the healthcare expenditure is of the household sector, and I think that second question that we had before the discussion started. So I've been familiar with it, and I'm very keen to hear Dr. Moore's view on the first three questions that I'd like to pose to him. Is that how do you see the current healthcare debates in India? Do you see there is a healthcare provisioning crisis? And if there is yes to number two, then where do you locate the crisis in? And so, Dr. Moore, how do you respond to these questions that I've posed?
Thank you very much, Professor Mahadevia. I also want to thank Ahmedabad University and the Department of Management Studies for inviting me, Dr. Pankaj Chanda, Dr. Ravi Meglani. It's just wonderful to be here. It's an August university, and I can see that it's taking a very serious approach towards the issues that are confronting us as a country, as a humanity, and I'm very pleased to participate in a dialogue with all of you. So these are three very important questions, and I want to give a quick answer to them so that we can get into a dialogue a little bit later. On the current healthcare debates, I would say two issues that I want to point out. One, as Professor Mahadevia pointed out, 85% of expenditure is in private hands. Individuals like you and me, we are spending for our own healthcare, and this is not unique to India. That is true of the developing world. But yet, if you watch the debate on healthcare as it concerns developing countries, and certainly as it concerns India, it's entirely focused on the 15% that the government is spending. And really, it's almost as if the rest of the money doesn't even exist in the system. And it's true when global institutions discuss health. It's true when our own scholars discuss health. Everybody is discussing what to do with the 15%. So that's, I would say, one debate. And the second, which I think in the current context, which is an important debate to have also, ma'am mentioned it, when we see the response to the crisis that has been, visible to us from our government, but also across developing countries, it seems almost like an import of what you would have seen in a European context, where there is a lot of emphasis on centralization, a lot of emphasis on hospitalizing people, a lot of emphasis on getting new ventilators and advanced treatment equipment. In my view, both of these reflect somewhat our weaknesses. Our strengths are in the community. Our strengths are in trying to build a distributed response. But yet, one aspect of the question is, or the response is that there is far too much focus on the small amount of money the government spends. And then on the current pandemic, far too much of the focus is on hospitals, machines, and really not as much on what actually can be done in the community around us. Clearly, I think there is a crisis in terms of healthcare provision. The reality is that we in India spend 5%, give or take, depending on how you count it, of GDP. It's almost 10 lakh crores. Of this, 1% is spent by the government, 2 lakh crores. So if you look at 2 lakh crores, one could argue that we don't spend enough money, and therefore it is reasonable that we should have these kind of health outcomes. But if you look at the total amount of money that we spend, and not just in Kerala, which of course spends a lot of money, but also in some of our poorer states, which is close to 7,500 rupees per capita. In purchasing power terms, this money is comparable to amounts being spent by countries like Peru, Nicaragua, Jordan, Thailand. And these countries, if you take the rankings of health systems, are 40, 50 ranks ahead of us in terms of outcomes. In fact, our results are comparable to that of Ethiopia, which spends a quarter of what we spend in terms of total healthcare. And of course, there are some states that are performing better, like Kerala, like Himachal. But if you look at their aggregate disease burden, it's very high and very inconsistent with the total expenditure that is being incurred by them. The third question ma'am asked me is, so if indeed we have a crisis, what is the center of gravity of that crisis? Where is it coming from? I'm very much a student in this area, so I don't have a firm idea here. But I certainly believe that one of the gaps, and which is what brought me to this August University to have a discussion with all of you, is that a lot of the ideology, a lot of the thinking that informs the approaches that we want to take has remained somewhat stunted. It has remained focused on this old commanding heights ideology, in which the state is the be all and end all in all spheres of economic life, both production of services, private goods, steel, cement, motor cars. While some of the things have changed, maybe the imagination continues to believe that's the ideal that we are shooting for. And there is no scholarship that looks at the objective reality and says, well, indeed, we might even want that. One could debate that, but let's assume that maybe that's a good endpoint, but there is no money. Very little money is there. And one of the areas, and this is something on which I'm hoping we'll have more conversation, because Professor Mahadevia is an expert in this. One thing that's been puzzling to me as somebody that is coming in new to this work is that by focusing on the business role of the government, the role in which government behaves like the private sector, for some reason, we seem to have absolved the government of the role of governing. Now, whatever we may do, one thing that puzzles me is, why does the government somehow wish not to govern, but to be a business? Why does that role seem much more attractive to it than a role that involves governance? So, I think these are some of the areas in which, I think, we need more answers, more attention. And I'm hoping that in the discussion, and maybe subsequently some of you are interested, we can really, start thinking about research projects and ideas as to how do we go about answering some of these questions and find a way out for our country and our people.
Indeed, what you said, Dr. Moore, is very interesting, that government has got into the business of business, and government is asking business to do public works or public activities or philanthropy or charity. And that's where there's a mixing of roles of the systems that we see today. So how do we go ahead, in your view? As our title says, that we would like to deal with it systemically, and what's the approach that you are putting forth before us who are just hearing and discussing here?
So, ma'am, that's a good question. And, I wish, of course, that I had a clear answer to this and we could all go home in 5 minutes. Unfortunately, this is an area where I'm looking for partnerships. I'm looking for conversations and dialogue. Just to give you a sense of what is the systems approach. One aspect of systems approach is you have to consider all dimensions. You can't, those of you that have studied climate change, those of you who studied gender issues, urban issues, you can't look at just one thing. You have to look at the whole system together to try and understand what is going on. Why is there such a lot of tuberculosis in Bombay? I was discussing with ma'am. It's big, one of the reasons is that the city in its slum redevelopment plans is violating building codes that was set up in 1926. It's a funnily named building code called the 63.5 degree light rule, which, if you come to Bombay, you should be sure to visit, BVD Chawls, which is somewhere in midtown of Bombay now. And you'll see beautifully designed buildings which adhere to this rule. But if you go to the newer slum redevelopment work, you don't see it. Right? So you might say, well, how is health linked to building codes? Right? That's kind of a systems question, because you're trying to understand where do multiple things come from. One of the areas in which I work to try and explore this idea more, I have a paper that I'm working on cesarean sections. And one thing that's curious, in cesarean sections, the pat answer, as soon as I tell them, oh, in Telangana, Kerala, you're getting a lot of C-sections, the pat answer is, oh, the profiteering private sector. But, as systems thinker, you have to go deeper into that and understand what is driving this whole underlying phenomenon, right? Because it's not just the private sector that is doing high C-sections, it's also the government. In fact, in the district of Pathanamthitta, which does not have the constraint of doctors, because one could argue, as Foxy has done in its public position, that the reason why the public sector has lower C-section rates is because it can't find the surgeons. If it had enough surgeons, it would actually do as many, if not more. And if you go to Pathanamthitta, that's the one district in which you see the public sector is doing more C-sections than the private sector. So, again, you wonder what is going on. And I certainly believe one of the issues is, that comes back to the original question that we were discussing, that the state and the private sector have an identical conception of themselves. They both view themselves as private businesses, competing for market share. And as a result, they are locked in this vicious circle. You do more, I do more, you do more, I do more. And that competitive loop is producing higher and higher C-section rates, both in the government and in the private sector. My interest as a systems designer is to understand how can I make that, this is called a reinforcing loop in systems design, kind of jargon. How can the reinforcing loop continue? I don't necessarily want to balance out at this current level, but how can I start the process backwards, which is I do less, you do less, I do less, you do less. So that gradually we cycle downwards into a holy spiral rather than the vicious spiral that you see just now. So that's kind of systems approach, and I'm happy to get into that specific example more if you want. But I also want, since I'm here in this business school, to try and point out two specific areas that I feel would be of interest to you as students and as researchers to explore. And I'm eager that we start with Ahmedabad University, with the School of Management, to build out some of this work. I am already working on some of these questions with Indian Institute of Management Udaipur, with Indian Institute of Management Indore, with Indian Institute of Management Visakhapatnam, and with the SP Jain Institute of Management Studies. There are faculty members that are interested in different aspects of these and other questions, but I'm hoping that there'll be a lot more scholarship coming out of this. So just 2 points. You saw the question that was put up in the poll earlier. How much of the money for healthcare is spent by the private sector, by individuals themselves? And you saw that many of you agreed that we spend most of the money. Right? And what perhaps you may not know is that that is indeed right. And it's as much as 80% that money. In fact, the richer the state is, the higher the contribution of us as individuals in healthcare. The poorer states, the government does more, the individuals do less, not a lot more, Individuals do the bulk everywhere. The difference is between, is it 70% somewhere and 80% somewhere else. And individuals spend a lot of that money on primary care, not necessarily because they want to, and I will get into that as a second problem, but because the way the financing mechanisms in India are set up, where you have to go with money in your pocket to actually buy anything in healthcare, the only thing you can really afford with that financing mechanism is primary care. You can go to a pharmacy, you can go somewhere else and buy the medicines. Now, in any other market, if I had told you that there is a massive demand for products and services, you would expect that market to evolve to be a high quality market. Look at the automobile market, look at the scooter market, look at the motorbike market, the toaster market. All these markets have evolved to produce high quality of response. This has not happened in primary care. Even in a rich state like Kerala, the missing piece is primary care, which, if you ask me, in a well-designed system, should be the dominant part of the healthcare in terms of actual healthcare being provided. In India, the money is being spent, but the quality of what you're getting is not enough. Kerala has some of the highest hypertension burdens in the country. Punjab has some of the highest rates of kidney failure in the country, which is why they're getting a lot of dialysis going on that is paid for by a variety of insurance schemes. And it's a curious situation why that is going on. One factor that I think is interesting, and those of you that work in marketing might find this somewhat curious, and we have a nice paper out of Mehsana that was done to look at behavior of patients when they consume tuberculosis services, is that patients tend to be disloyal. They do not stick with one provider for too long. If you introspect and ask yourself the question, how many providers have I seen in the last year? My understanding of the data is that on average, Indians would have seen 5 to 6 providers in a single year. You cannot build a good primary care system with this kind of distributed expenditure. And a consequence of this has been that those startups that came into the market and said, I'm going to start a primary care venture because Indians don't have good primary care, and they spend a lot of money on primary care, but they get bad outcomes. Most of them have failed or have failed to grow. Right? And it's an area that I think is an important area that we need to get into to try and understand, because if we can get to the bottom of it, without waiting for the government, without waiting for the WHO to figure this out, we will be able to get better value for our customers in terms of primary care. The second, and I'll quickly go through that, one of the issues, as you correctly pointed out in the poll, that a lot of the money people spend is on primary care. Right? But what about hospital care? What about tertiary care? What about cancer? What about bypass surgeries? Right? Why do they not spend more money on that? Well, one of the reasons is that if you look at a 5 lakh, 10 lakh rupee surgery, right, the only way, and I'm sure there are students of finance in here that are listening to this conversation, the only way that you pay for state-dependent, state not as government state, good state, bad state, that Markovian state is what I'm talking about. If you talk about expenditures that are state-dependent in the Markovian sense, right, the only way to create an arrow-debru complete market is to develop arrow securities that allow you to move money from the savings, loans kind of environment to an insurance type environment. Right? Nobody in the world pays for hospital care out of pocket. And 2 consequences have happened for this. One is that a lot of people choose not to seek any care. Or if they do actually seek care, we have as much as 6% of our population falling below the poverty line because of the shock each year, because of the shock of this kind of expensive healthcare expenditure. And third, which is also curious for those of you that work on areas like industrial organization and market structure, you'll find that the private sector, we talk so much about it, and you have, somehow when you listen to the talk, you think of, my God, this is some evil, hydra-headed monster sitting on top of the system. Well, in a 10 lakh crore market, the total private sector does not exceed 15,000 crores, the formal corporate private sector. It's tiny. The largest player in any other sector, in banking, in steel, in cement, in power, is 20-30% of the market. In India, in healthcare, the largest player is less than 0.5% of the market. So both sides have remained very, very puny, because the mechanism that we seem to have in place to pay for these services is just wrong. So clearly, there are areas of work that I feel should be of interest to you as researchers and as academics that I'm hoping we will get into, because what I can tell you, sadly, the world is not interested in these questions. For some reason, the global institutions, the scholarship coming out of the top universities in the world, including where I'm a student, Johns Hopkins or Harvard School of Public Health, all of it is stuck in the Stalinist commanding heights idea. They're all focused on the 10-15% of the market, and not just for us, for the whole world, whole developing. They don't have those systems. They don't live in environments in which their systems operate in the Stalinist way. But somehow in the developing countries, they are very comfortable inflicting this very old idea from the 1920s and not even discussing any alternative. Of course, a country like India, why should we lament that the world is not helping us? We can do it ourselves. We have enough scholarship, enough capability. I come from a finance background. We have not waited for the world to tell us that we need small finance banks, or we need derivatives, or we need something else. We have developed these ideas ourselves and have gone out and built something quite interesting. Ma'am, in fact, one of the questions that I had for you, and I kind of hinted at it, but it's something that I feel maybe if you have a perspective on it. One was this question that it's been puzzling me a little bit. Why the refusal to govern? Why is it that despite something that is obvious in the market, we keep arguing government doesn't have capacity to govern. But I worry that actually before capacity comes desire. Why is it that we are stuck in this idea? Because governments have changed, ideologies have changed. I can understand that in the 1940s, 1950s, Pandit Nehru had fewer choices. It was not obvious what the world would look like. And maybe the idea that the government would be doing everything, that there's no need to govern. If I'm producer, I'm consumer, I'm financier, I'm everything, governance is not important, right? But in today's market, that kind of thinking is hurting us. We're getting Jammu, for example, that I mentioned to you, my Kashmir district in Jammu and Kashmir has 94.5 C-section rates. Even deep market enthusiasts will tell you this is a bad outcome. And government is not far behind. It's at 70%, right? Which is, the average for Telangana, which we are also unhappy about. So I'm just curious to hear your perspective on that.
No, this in the healthcare sector, but it's just not the question of healthcare sector. It's related to all other sort of what we call now a basic needs sector in terms of water, sanitation, which are both part of the preventive healthcare and healthcare provisioning. We envisage a system, as you rightly said, that the state does the provisioning and people are the client of the state and that they would receive the goods. But in India, at no point in time with regards to any of the services, we have come any closer to what we thought. So for example, when I deal with housing or water supply, it's only reached a very, very small segment of population where there's direct government state provisioning of the services. And that same is with regard to state. And the whole idea of what you call Stalinist state in Indian context, we have this provisioning only in, let's say, Delhi situation that there is a very wide-based public healthcare system. But if you look at any other state, and I've grown up in Ahmedabad, I've never ever put my foot in the government or municipal hospital for any of the needs, a primary health needs or any kind of tertiary level health needs. And so we did indeed, what you say is correct, that we have sort of got it wrong right from the beginning, and we imported this model from the European context after the Second World War, thinking the state is the provider. But the key conundrum we have is that, as you pointed out, both private sector and the public sector are racing towards the bottom in terms of quality of services. As you said that your Mehsana study did come out with the finding that people are changing their healthcare providers. There's no sort of allegiance to one. Probably we need to look further into, but is it because of the private care? And I think there is a lack of trust that has happened with regards to either private doctors or public healthcare system. And so that's really a problem. On top of that, we do also hear in the media and all kinds of stories around of how there is enmeshing of private interests in the public sector, or how individuals are sort of driving decisions in the public sector to sort of meet the private interests. And I don't know, there was a story in times of COVID in Gujarat itself that we have heard some such stories coming out. And in Ahmedabad, the situation of civil hospital and other is really bad, but we also haven't heard about any good private sector hospital in terms of providing. So that's a big question of what do we do with regards to dealing with both at primary and tertiary level when in a situation where we have total breakdown of the system that we see today. Now, if we were to look at the system, and I'm going to ask you a question after this point and know more about what you're thinking about this as a sort of systems approach. Now, if we are now in the concrete terms in COVID-19 situation, we have opened up in June the private hospitals for the COVID patient care only in June. We knew that this pandemic is there in globally since December. We knew that India is integrated with the global system, and at some point in time we are going to get some infected person and it's going to spread given the kind of densities that we have. We knew that public healthcare system is not adequate to meet. We don't have adequate beds. And in Delhi, if there are adequate beds, then we know that the rest of the country, we don't have adequate beds. Then why did we not bring in private sector earlier? Why did we not have negotiations right from the beginning with regards to how many beds that should be there? What should be the price of each bed? How should be the financing mechanism? Who would pay? Who would bear? Can the CSR be counted as a part of the contribution of the private hospitals? Because CSR is mandatory for private sector. Then why would this not be considered as a CSR and so on? These questions should have debated, negotiated, and a scheme put in place right in the beginning. Once we went for the first lockdown, we should have thought about this, put this in place so that we're not finding now situation where bodies are lying in the hospitals, and in Ahmedabad we have situation wrong body given to wrong patient and so on. And it's really a disaster that is being, so how do you look, let's see if we wanted to fix this COVID kind of a situation of both private sector and public sector racing down to the bottom in terms of quality and ethical practices that we see. How does the systems approach that you are talking about be actualized, or how do we put that in place? And what are your views in concrete terms?
Yeah. So ma'am, as I was saying earlier, I feel there are two issues that we need to be cognizant of in terms of the COVID-19 strategy, just narrowly focusing on this question, because you're quite right. The water is rising rapidly, and Gujarat, Ahmedabad are very much in the eye of the storm now, and it will spread elsewhere. And my own interest, ma'am, would be rather than to go back and do analysis as to why they did not act. The question that I'm, in fact, doing a lot of work on, even as we speak, is what should we do going forward? And I feel there are two fundamental errors of strategy that we need to correct. One, as you pointed out earlier, that we fail to recognize, Italians, I don't know if you've read, New England Journal of Medicine is a journal that is written only written by doctors for doctors. Individuals like me are not even welcome to read it because we won't understand anything that's going on, right? Because it's if you look at the language, it's all very complex language. In that journal, they decided to publish a plea by the Italian doctors from Lombardy to say, do not do what we did. Right? What did they do? They thought that by focusing on individuals, on hospitals, ventilators, centralizing things at hospitals, they would be able to fix it. They could not. they got overwhelmed. And Lombardy, ma'am, has one of the best equipped hospital systems in the world. You're comparing Delhi with Ahmedabad. I'm comparing Lombardy with anywhere in the world. Right? Yet they were overwhelmed. They had to make decisions of who to ventilate, who not to ventilate, who is ready to die, who is not ready to die. Doctors will experience post-traumatic stress disorder for decades because of the decisions that they took. These are not easy decisions for anybody to take. We might imagine for doctors it's very easy to do. Right? Clearly, we did not anticipate the scale of the crisis. Somehow, I think whatever I'm hearing, the dialogue, we continue to believe. And when I talk to bureaucrats and government officials from states which are not yet seeing a peak, they believe their state will be spared. It will not happen here. It will happen there, right? Initially, when it started, we believed that it would happen in other countries. It would not happen in India, right? Somehow that instinct continues to persist, despite people like Dr. Gagandeep Khan pointing out repeatedly that this is a respiratory virus, it's going to spread, and that the only real way to deal with it is to be prepared that this crisis is going to be much wider than we imagine. Right? And I think some of what you're saying about not having the conversations early has come from that. Partly also it has come from our old instinct, which is the commanding heights instinct. Why should we not use this as an opportunity to build our competitive capability? One of the reasons why my hypothesis is you see such high rates of C-sections in Telangana and Kerala, because these two states, the government is losing market share. Even in the narrow business that the government is in, which is the delivery of babies, which is very much a private good, it is not a public good. Even in that narrow business, they are doing only 30%. So in order to gain market share, they're using whatever they can in terms of state power to try and get, and if that means they follow the private sector and do too many C-sections, they're very happy to do that, right? Because that gives them market share. Maybe that thinking was there, and maybe that thinking is still there, that, how do we use this as an opportunity to continue to, build our primacy and build our structures? Because the second area I would say is a discomfort of governance. Because if people don't report to me, and people are not, when I walk into the room and people don't stand up, I don't know how to govern them, right? Because the notion of governance involves dialogue, discussion, building public opinion, going out there and convincing voters, convincing individuals that this makes sense. Even, the strange outcome that you saw in Britain about Brexit, you could see how politicians were, frantic that they needed people to agree with them and somehow persuade people that it makes sense. Now, this is a skill perhaps we didn't have. And maybe that's why we got a little bit stuck. So clearly, having that dialogue, making sure that we understand what to do is going to be important. But I would say, ma'am, the bigger problem in my mind is not so much the public-private and the shortage of beds. It is an issue, no question. Is this notion that we will solve this problem in hospitals, I think is a fundamentally flawed notion. We know this disease to the extent we can know it. 80% of the patients do not need much attention, but 20% do. In a large country like ours, in a large city like Ahmedabad, 20% is not a small number, right? But most of these 20%, somewhere near 80 to 90% of this 20%, actually need simple oxygen. That oxygen, if you have old people at home, you would have noticed in many homes, is given to people at home. Many old people have actually an oxygen cylinder strapped to their wheelchair, and they have this little two prongs going inside their nose. Now, if something can be given at home, it can certainly be given in a community center. It can certainly be given in a panchayat hall. Right? It can certainly be given in a small clinic. Now, we will have to switch strategy to think about this, right? And to become conscious that we do not have the ability to transfer everybody. In Lombardy, ambulance workers started dying. Not just nurses and doctors, because you were transporting people needlessly. They could have been treated right there in the community, but you forced them to come to hospitals. And in the process, not only did you not help them, you did not help your health system. And then the other area, which I think is very important, which we need to be conscious of, this disease has a unique mortality profile. It really hurts people above 60 years of age much more strongly. You cannot issue a circular and say people should wear masks. People are not wearing. I live in Koramangala in Bangalore. The richest of the rich are not wearing it. This disease does not make any distinction. Right? You have to work door by door, person by person, family by family. And for that, you have to turn to the NGOs. You have to turn to local communities. You have to turn to your panchayat leaders. I think these are the directions we will need to go, ma'am, if we are going to solve this issue.
So what I understand from what you are saying is that we need to develop a more decentralized system of healthcare, one, and that we need to also look at what are the diseases and issues that can be taken care of at the local level, a community level. So if there's a panchayat level in urban areas, we at least have urban health centers. Ahmedabad has one urban health center per ward. We haven't seen much of its role in dealing with this. We could have created more facilities at the ward level. And having created that facilities, the second question then would be, if we were to look at the systems approach, there would be, who is going to finance this? And so do we have a budgetary allocations? I mean, overall budgetary allocations is there, but could you have more money available in the municipal budgets and panchayat budgets? Which funds, part of the funds, other part of the funds could come from on maybe CSR at the local level. Third could be come from the insurance sector and so on.
Opposite is happening. What is happening today in Ahmedabad, for example, is that the rich are occupying the free beds. Right? Now, if, for example, the government permitted housing societies and told them, you set up your own centers. There are many providers today that have come up. Companies like Portia and others are there. Apollo Home Health. They will be very happy to set up the structures for you. They don't cost very much, to actually set up and operate. At least the rich would stay out of the public hospitals, and they would stay out of the few beds that are available. I don't know the Ahmedabad situation, but in Bombay, for example, actual ventilator usage is quite low. The problem is all the beds that were meant for ventilators are being occupied by people who are feeling slightly sick. I'm not saying they're just there for fun. They're feeling slightly sick, but there's no other solution for them but to come here. And they don't want to be discharged because they know if they get really sick, they won't get that bed again. Now, if you gave them other options, in another conversation with another state, we are discussing the possibility that these large companies like TCS, etc., big IT companies, they have staff coming back to work now. They are worried that what if somebody falls sick? Earlier, people were staying at home, it was fine. But now they're coming at work, they're coming to office. Can they set up oxygenation centers? Very easy to do, very quick to do. That at least takes away the load from the existing infrastructure that you have. And you can then start to accommodate a lot more of the poorer, a lot more of the middle income where they're actually needed. Now, clearly, all of this will not work. We will need new money. We will need to find new money to come up with. I don't have clarity on where this money will come from, but my sense is the only entity that really has the power to print money is the central government and to issue bonds. And I think there is debate going on there as to how should they finance all aspects of healthcare expenditure. My own belief, though, ma'am, is that without money or with limited money, with clarity of policy. In fact, one state government asked me, "Ki paisa kahan se aayega?" I said, "Sir, we will of course have to answer that question. But first, let us answer the question of policy clarity. Because, ma'am, I think the bigger problem is we have to develop a new muscle to persuade, to guide, to request, to collaborate. This is what the essence of governance is. Somehow, our government, not just this government or that government, I have not seen any government have that capacity. They love to issue circulars, diktats, notifications, full page ads with 200-page worth of text in it. That is not going to help us.
So yeah, we've talked about systems of setting up supply systems from bottom to the top in a hierarchical sense, in a more decentralized fashion. We'll have to think about financing it, as you said, not just even bonds at the central government or top level, but if my society was to do, are we willing to pay for extra healthcare facilities being provided, or I'm paying some maintenance charges? Is that going to be partly diverted for healthcare when such kind of pandemics come? But the third question, and which is more important part of the governance, is that who's going to monitor the quality, the regulatory part? Because when you say governance, governance is role of both all state, private sector, and this community together is doing appropriate tasks at appropriate level. But finally, it is the government. If you have an honest government without malintentions, then you would have better regulatory mechanism. I mean, today we know that in police, if you don't want to go to police because you know whether you'll get justice or you'll be sort of fleeced of your money, and there would be more rent seeking coming out of it. And that's the kind of image that is there in parts of the state apparatus. We need to also improve that kind of state apparatus, because leaving it completely to the market and healthcare then eventually can become a monopoly commodity. In that case, we need some form of good regulatory mechanism and citizens oversight on this kind of mechanisms, which basically means that we have to fix this system afresh in terms of thinking, and politicians should probably have courage to say this rather than saying my baap hum log karenge. I mean, I think can't say that no, we would develop a system where it's a partnership system rather than saying we'll do everything.
Yeah, ma'am, I think it's a very good point you're making, because I have studied health systems quite extensively around the world. You know, the health system in which government pays 100% and provides 100% is very rare. In fact, the only example in the world continues to be Cuba. There's no other example in the world of that Stalinist ideal, right? But every health system has 100% governance. Japan is a rabid market economy. They trade everything, right? Switzerland, full market economy. Even privacy and secret money, they are the haven for it. But in healthcare, there is 100% governance by the government. Full price control, full licensing, not just of stents, every detail. In Japan, if you have 1 square inch wound, you pay a price that is written in a blue book anywhere in Japan. If you have a 2 square inch wound, there's another price that is given, right? It is actually, we knew how to do this pre-91. You know, we decided that we will withdraw the state from many sectors, right? And we withdrew from the healthcare as well as a governance player. But the other problem, ma'am, which again kind of hits a little bit back at the whole self-image of the state. If I as a state believe that my primary business is to run a business and not to govern, my big fear about governance is, what if it hurts me? What if I try to govern and I'm thinking that guy will get affected, but it turns out that I will get affected? I don't know if you've seen the work of Jishnu Das. You know, he's done some very nice work he sends, what they call standardized patients. So these are patients that are coached to say that, sir, I woke up in the night, my chest was hurting, and I felt really very sick. What can I do next day? So he's in a clinic. Classic signs of having had a heart attack. Right? Now, the question he's observing and he records, secretly, because the doctor doesn't know that this guy is making up the disease, is to what questions are the doctors asking him? From his research, which is actual patients, not somebody theorizing about the doctor. This is an actual experience being recorded. Consistently, he finds that the worst outcome comes from the most well-trained government doctor in a government facility. That is the one who doesn't ask any questions. There's only a 6% chance that such a physician does not do damage to your health. He will give you an antibiotic, he'll give you something else. But interestingly, the best doctor is the same individual practicing in the evening in his private capacity. Right? So it's a clear example of how the problem is not with the individual, but with the system within which the individual has been placed. Right? Now, I fear, and I've seen this unfortunately in other sectors as well, that the government, part of the reticence of the government to govern comes from the fear that a well-governed system may find government itself, the government-owned machinery, as doing very, very poorly. And maybe that's one of the things that holds it back. Because, and it's an interesting example. If I compare Kerala with Bihar, right? In Kerala, the government is a small player, but it runs, whatever it runs it very well. Now, what that does is, and this is an industrial organization type argument that you make. Again, it's a systems argument that I don't think that was its intent. It happened accidentally. Because it runs a good public sector, the private sector now knows that if it reduces quality below a certain level, the public will go to the public sector. They will not come to the private sector. If they charge too much, again, they will go back to the public sector. As a result, this tiny public sector of the government crowds in an equally good quality public sector, a private sector. In a poorer state like Bihar, the opposite happens. Because the government itself runs a low quality machinery, it crowds in an even lower quality private sector because it knows it can get away with anything because the patient doesn't really have a choice. So now these are subtle skills. I don't know if in our response to COVID, we will build them. But if we are to govern our system, we're going to have to use, and this is where your students, your researchers, marketing professionals, finance professionals, public policy professionals, I would submit, would need to get into it and really ask these questions de novo using all of the capacity that we have, and not be guided by the global wisdom of what India should be doing and what Indians should be doing, because my belief is that they just are not asking the right questions. In fact, I would submit the opposite almost, that they are pushing us in a direction that is inconsistent with our well-being.
Thank you, Dr. Moore. We can go on, both of us, discussing about this because it's really an area that is very close to our hearts. That now that you've raised the issue of questions, I think people are waiting for comments and questions, and I can open it up for any comments on the discussion. I think I've seen many of the chats being put forward, the way the people are passionately putting their viewpoints on the chat. So now it's open to ask questions or raise issues or your opinion on the topic that we are discussing.
Thank you, Darshini. Thank you, Nachiket. The chat box has been overloaded. So thank you for leaving some time for the questions. Your discussion was on a roll. So obviously none of us wanted to interrupt that. And as you said, Darshini, this could have gone on for a long time. But yeah, it is good now to open it because we have dozens of questions. We don't think we'll be able to take all of them, but let's start. So I've been looking, and our colleagues have been looking at some of the questions. Let's start with some, and then if Darshini or Nachiket, you directly notice some question you want to address in the chat box, feel free to pick up. But just to get us started, there is a question from Divyesh saying, India being a poor country with more than 60% of the people being poor, do you think health should essentially be a government job or should private sector come in?
I mean, there are many questions hidden in that. I would submit to you, we're not a poor country in the relevant sense of what we can do. So just give you a number, right? Mayo in the US does an open heart surgery, what they call the diagnostic related group, which is across all surgery types, and charges $100,000, $1 lakh. Narayan Hridayalaya in Bangalore, right, has a DRG for the same procedure at 1 lakh rupees, which means for 1 rupee, you buy $1 of services. We spend 7,500 rupees per capita on healthcare. By that extreme logic, I'm not telling you that that is the logic I myself subscribe to, but just to make a point, we are spending $7,500 per capita on healthcare. This is more than the money Britain is spending on healthcare per capita. So I would submit to you, we are not a low spender. What about poverty? I would submit to you that this is an image from the 60s that you have brought up. 60% of the people are poor. When I was, starting out my exploration of microfinance, I would go to Mirzapur in eastern UP, amongst the poorest parts of the country. in that district, a 500 rupee loan would attract a crowd, right? Because people needed money desperately. I would submit to you, go back there today. If you're not talking about a 25,000 rupee loan, you will not get an individual to show up. In fact, the situation is such that the RBI had to relent and increase the limit that microfinance companies can lend to borrowers from 50,000 rupees to 2 lakh rupees, because people want a lot more. And the third issue, which is another issue to be conscious about. Yes, in the ideal, if I had a clean sheet of paper, I would submit to you that the government should not be in the business of building steel plants and running airlines. Right? They should be using this money to provide what I would call truly public goods. We lose 1,200 persons a day to tuberculosis. It's a classic infectious disease that needs a public health response. Right? So I would submit to you, let the government spend that money, but we don't have that clean sheet of paper. I am not running the government. I cannot go there and say, give me 60% of your money, right? So there is a pragmatic perspective to say, good idea. 70 years have passed. We have not been able to persuade the government to change from 1%. If anything, as the states have gotten richer, they've reduced their contribution to healthcare. So, from all perspectives, yes, it would be ideal if the government paid the money. I would submit to you, though, is that there is a lot we can do for the very poor, for the middle income, and for that matter, for all of us, the so-called top 5%, to build better healthcare with the resources we have today.
Yeah. Okay, that's good. Since you mentioned microfinance there was another question related to microfinance. And Pooja in the chat room is asking, do you think microfinance has a role in healthcare for the poor?
I would submit to you that microfinance has a large task ahead of itself right now to get basic financial services out there to poor people. Now, it is true that primary care, and I don't want to get into the whole finance discussion of ROW securities, but in primary care, you can actually finance it through good savings and good loans programs. If you look at Singapore, for example, Singapore's health system is an interesting health system. It is called what, in the jargon, we call it HSA plus CAT, health savings account plus catastrophic insurance. So all of the basic care, primary care, even the simple secondary care is paid for by people with their savings and loans. Now, if the microfinance institutions were to do their job well, and if the small finance banks were to do their job well, and if every individual had good access to credit and savings, it's possible that some of the impoverishment that you see would not be there. But today, unfortunately, even for a low expenditure amount, 5,000, 10,000 rupees, I might have to sell a house because I don't have any savings and I can't borrow the money easily. There is a role, but I would say role much more driven by fulfilling their core purpose and not getting distracted into doing something else.
Thank you. There are some very substantial questions and we'll get to them in a couple of minutes, but just I'll do a quick fire reading out of some quick comments more than questions. If either of you have a response to that comment, please do, but otherwise it's just a comment. Selvarajan in the chat room says, isn't healthcare for majority, it is sick care for a minority. Describing India's approach to healthcare. It isn't healthcare for majority, it's sick care for minority. Any quick thoughts on that, or we leave that as a comment?
I think Dr. Moore did explain that he said that in context of COVID, but that's generally the case that we do have public. I mean, for example, Ahmedabad hospitals have got, some of them have got very, very good machines and everything for care. But it's monopolized by people who have access to it through political connections, or you have money. And so you have this best facilities which are lying in public hospitals are used by the richest of all. And same is the case in AIMS. We hear the AIMS stories of people with Delhi government and high officials getting into AIMS, and people are waiting outside on the footpath. and the stories there are really bad. So it's not it's a sick care, it's the scare of the rich that is happening in our system rather than care for everyone. And commonly because there's a supply shortage, it is a tendency for the rich to monopolize whatever is the best care available.
Yeah, that is one. And I think one other, I believe the purpose of that comment was more about, and there are many such comments in the chat room, that we are more focused on sick care as in curative rather than preventative.
So
We are not
in that
focused
case,
on care, we focus on sick care. Mm.
Ravi, I would just wanted to say, because we are focusing today on sick care, we proceed. What we have is, I think there is a confusion when we talk about health. There is preventive part and the curative part. We're talking about the curative side, the healthcare system. The
Yeah.
preventive part is much more longer term changes. For example, we know that I'm looking at what I was doing urban planning, for example, the infant the infant mortality rates and other diseases started declining when the sanitation was provided, and the
Yeah.
medicines came much later to treat, or penicillin came much later before after sanitation came in. And I think in many cities we have wonderful museum of just walking you through the drains to preventive healthcare mechanisms. So the world started with preventive healthcare mechanisms as we started to urbanize. So in this chat, we are only focusing on care, that is curative part of the health thing. And that's why the discussion has been focused on that. As if we go in the direction of preventive issues, it's much more complex.
Yeah.
And
Then
also much longer term changes can happen there. In curative part, we could still act now and see changes in coming half a decade or so.
Yeah. Okay. While we are reading through some of these quick questions, just to remind, as we said in the beginning, if any one of you want to come on microphone and ask a question verbally instead of typing it in, raise your hands in the participant window using the raise hand feature, and we'll come to some spoken questions in a couple of minutes. One other quick comment from Narendra Agarwal. I think it's the inability of the private sector to build confidence in their professionalism and their integrity, which makes the public to move to multiple service providers. In response, I think, to Dr. Moore's comment earlier that on average, an individual goes to 5 or 6 different service providers. There's no loyalty. So that's probably because they have the profession hasn't been able to build confidence in themselves.
No, so the question, it's an important comment. The question I would have is basically, it's not an actionable comment. What do I do with that? Because yes, I can go to a temple and pray that there should be more confidence, but that won't happen, right? And in fact, that brings up all these key questions, right? What is the role of the government in this? For example, the US, which does not by any means a model health system, right? What it does is that, because it's, it's primary care, but primary care worldwide is largely private sector. UK, we think, is government. Actually, the private care paid for by the government, but delivered by the private sector. Right? What does the US do? US identifies high quality primary care and allows it to brand itself as a federally qualified health center. So it can say that I am recognized by the government. Right? But that requires a partnership. India has no such scheme because the government believes that if it recognized a private sector entity as being high quality, then nobody will come to the public sector. Right? So if you said, no, I'm not interested in the public sector or the private sector, I'm interested in service to the public, right? I would want to think about how do I solve this problem of trust? Because see, ultimately, if we believe that the primary motive of a private sector provider is to make money, right? Why is it that in automobiles, he makes that money by making good cars, but in healthcare, he makes that money by making bad cars, right? Obviously, it's the same private sector. In fact, oftentimes it's the same company that is doing this and that. Right? Is there a role we can play? And in fact, I would submit to you that this is an area where marketing professionals, would benefit. I mean, the country would benefit a lot if you got into it and started to understand health services marketing very, very carefully.
Yeah. Okay. That was a very good to come back to that comment, because there are many such comments about a lack of credibility, lack of trust, a lack of ethics in the profession, and so on, which is leading people to seek multiple opinions and jump from provider to provider. Moving on to one more substantial question, and then we'll see if there are hands raised to ask question. This is from our very own Professor Pankaj Chandra. It appears that the absence of a citizen's oversight of public service delivery is ensuring that the state machinery can continue to remain unaccountable, or the state's capability is so low that is unable to imagine new models or partners who those may have, or partners who may have ideas. Is there an inability to experiment?
So I think that's a terrific question, Dr. Chandra, and really need a whole debate as to how does one set up a governance structure. I don't know if you had the opportunity to look at some of the World Development Reports. I think the 2004 report was dedicated to this question. And there are many academics that are actually spending a lot of time trying to understand what is an optimal design of a governance structure. I would submit to you what you are hypothesizing might be an interesting direction to go is labeled in that community as short route accountability, in which what you're saying is let the citizen directly govern the service provider that serves him. I would submit to you in the extreme, that is exactly what the market is. In fact, what you are implicitly saying by citizen accountability is that give it back to the market. Because the best way for the citizen to hold the provider accountable is for the provider not to get any money, citizen to get all the money, and the citizen to pay the provider based on services that the citizen wanted. Now, this would work well and should have worked well, because effectively this is the system we have today. Short route accountability, which is what is called private sector, right? Unfortunately, it doesn't work because health, again, that's a separate long conversation. If you look at the welfare theorems, the first welfare theorem, the Adam Smith's invisible hand, which suggests that if only you let the market be, and let citizens hold providers accountable and pay the providers that are doing the best job, you will get first best outcomes, efficient outcomes. Unfortunately, in healthcare, even the first welfare theorem is violated. 94.5 C-section rate is an inefficient use of money. In fact, one of the reasons why Telangana continues to have a high maternal mortality is because first the state and the private sector decided to give a C-section to a mother that did not need it. But because they have poor infection control, unfortunately, the poor lady acquired infection from the C-section and then she died. And this is what produced the outcomes that you are seeing today. Right? So clearly, we need to find a way in which the short route is not the only route available to us. We do have a very powerful long route of accountability, which is via elections, via ensuring that we vote in the right politicians, and the politicians hold the bureaucrats accountable, who in turn hold the service provider accountable. Now, something is broken in the long route accountability, which is why we are looking for a shortcut, which is the market structure, which is short route accountability.
Yep. Okay. We are seeing some hands being raised. We'll get to them in a moment. Another question. India has a rich history of Ayurvedic health systems and community-based solutions, but as employment potential outside the villages with better pay, traditional knowledge is stopped being passed over generations within a community. So people are moving away from communities and therefore losing the traditional methods of addressing some of these healthcare issues. You think that's an issue, or?
I mean, so clearly if I go back 100 years, 1850s, 1860s, maybe longer than 100 years, the mature system of medicine was what we would call the Indian system of medicine, which Ayurveda is one example of it, but we have three broad categories, Unani, Ayurveda, and Siddha, which are called ISM systems. Now, they are part of the Ayush machinery, but Ayush is a much broader definition. It includes yoga, homeopathy, and other things. Certainly, Indian systems of medicines were very powerful. And in some ways, if you see modern medicine, it's a blend of the old and the new. So I don't know if you study ophthalmology, for example. The instruments used in ophthalmology were instruments used in Ayurvedic surgery in the 1300s. So it's not as if that has been ignored. Aspirin was a former Ayurvedic drug. Artemisinin, one of the most powerful anti-malarials, was an Ayurvedic drug. Right? Vincristine, it's a very powerful anti-cancer drug. Right? Comes from the vinca flower, sadafuli, I don't know what you call it, the 5 colored, 5 petals, it has a little common flower. Right? So in a way, what you've seen is a blending of traditional understanding with modern medicine. And in fact, in a molecule discovery process, if you can repurpose an Ayurvedic drug and you can show that it has been used for hundreds of years, you get a fast track approval because you can demonstrate to the approval authority that actually there is a lot of empirical evidence already about its efficacy and safety profile. I do not need to do a long-term trial. Right? And there's a whole industry doing exactly that work. But I would not go to the full distance and say, therefore, anything that is traditional, anything that is being done in that practice should be wholesale imported and brought into our current understanding. Ayurveda, for example, believes like meets like. So there is a fair amount of arsenic in the medicine. Now we know that long-term consumption of products like arsenic can lead to multi-organ failure. So you need to be careful about what is the type of Ayurveda that you're talking about. Right? The understanding of germ theory, understanding of genetics has become a dominant part of our current understanding. It's not Ayurvedic or allopathic. It is just our understanding of how human beings behave. Right? Now, to go back to a world in which you say, I do not believe genetics, I do not believe germ theory, I think would be a regression. So my own submission would be, there is a lot to be gained from examining traditional practice, a lot to be gained from trying to garner as much wisdom and information as we can. But I don't want anybody to assume that that's not already happening. To a large degree, it is happening. Meditation, for example, mindfulness meditation is now a part of mainstream cardiac treatment. It's no longer something that there's a lot of evidence base that suggests that it's verifiable that mindfulness meditation actually helps. There is, in fact, new work that is showing that mindfulness practice, when introduced early in childhood, produces lower, dysfunctional behavior in these children when they turn into adults. So again, and this is evidence coming out of the US. So don't assume that it's simply in India that we are, doing it and other people are not.
A very interesting question here for either of you or both of you from Dr. Hetal Javeri. If it's a lack of vision in the case of decision makers, as we've been saying, why is it happening that when generations of decision makers change, the short-sightedness in decision making still remains? So is there a problem in our understanding or of political interference? We can, the spirit behind the question, I guess, is that we could blame some decision makers, but generation after generation of decision makers keep showing that same short-sightedness.
Yeah, I would request Professor Mahadevia to answer it. I think this is an area that it would be a question I would put to her as well. I'm also curious about it.
So first thing, and my response to even the previous question, that we have a tendency, and increasingly a tendency, to look at things in binaries, either this or that, either this or that. And that's not taking us anywhere in any, so we think in black and white, everything is taught in black and white, that everything that was traditional is fantastic, everything that modern is something to be questioned and not trustworthy, and so on. And that's where the problem is coming from. I think, at least in Indian context, we have a lot more blending of the traditional with new practices and new ways of thinking. And there's a kind of, and that's what is Indian history, of assimilation of various knowledges over time. So that was a response to the previous kind of question. But in Indian context, it's not to do with the decision makers only alone. There's also there's a whole global way of looking at a problem. And when we decided to take state or the government role as primary in health, in housing, in education, etc., post Second World War, that was the way the global utopia was sort of constructed. And that construction broke apart in 1980s. And then we swung completely on the other side and said that we are now going to entirely go private sector. And the answer lies somewhere in between, in kind of finding the right answers as to who has what kind of a role. And that is what Dr. Moore has said is the term governance of a system with regards to health, education, whatever we think about. So it's the problem is that we construct a problem based on sort of blaming individuals and decision makers. The problem is not around individuals. Problem is more systemic, the way the questions get constructed, the way we look at the problem of, and increasingly, I think in India, our healthcare problem is increasing. It's getting more complex, because we are also getting problems of obesity and high income, which I think the developed world is kind of addressing. And we are also continuing to deal with problems of poverty. And so tuberculosis continues to be still very dominant in our context. Malnourishment is rampant in our system, which then causes further more disease outbreaks. So it's not the decision makers that it is. And increasingly we have lost our ability to debate and discuss and take decisions. For example, if I wanted to take a good decision about healthcare today, where is my data to take that decision? I was plainly interpreting the numbers of COVID infected persons. And I know that if I'm looking at data of numbers of March and April, I'm looking at one set of construction or the idea behind the data. If I look at the data of May, we were not testing everybody, we were not doing contact tracing, so we have select set of people. And so what we are comparing is, we're comparing apples and oranges when we are looking at data, because the way the data gets constructed, we don't know what we are doing. And so increasingly, we are taking decisions which are without any kind of basis. We don't have evidence, and I think Dr. Moore has said that multiple times, that we need to go and look at the problem and analyze it from bottom up, which is more evidence-based way of going about it, and that we are not doing. And then it's very easy to blame one decision maker or the other. What has happened is that gradually in Indian context, for whatever reasons, we have moved very, very far away from evidence-based policy making and actions. And if we are not going to do that, that's also a systems approach to handling any kind of a problem. If you're not going to do that, we will then have that we had a bad decision maker, we had this, we had that, and then we start blaming individuals, which is our very good pastime of blaming individuals about everything that has failed. So I think we need to, as a citizens, also be more scientific in the way we look at issues and problems.
Okay, all right. We are coming to the close of our originally scheduled time of 5:30, but if the two speakers are fine for another 5 to 7 minutes, because there are some really interesting questions, and we would try to get through 2 or 3 more of them. And to others whose questions we do not get to today, we are, of course, we'll have a record of these questions and who's asked them, and we will post them offline to our guests, and we will get back to you with some answers in the coming days. I think since everyone has probably heard enough of my voice, let's have a voice question from someone who's raised their hand. SAS Zoom 2, I assume that's not your real name. If it's not
Saurav.
your real name,
That's
can
Saurav.
you identify yourself and ask your question?
Saurav, you are mute.
Oh,
I am sure of.
Sorry.
I am sure of Sharkar. Yeah. So, yeah. So, yeah. So very interesting point. Actually, my point is about the research that you cited about Professor Jishnu Das about his finding that the government sector doctors fare better when they do a private practice rather than they do in a government practice. So I think in the same study, there was an additional finding where he investigated quack doctors, which is actually untrained doctors, and saw how they performed in the treatment. And there he ranked, I think they ranked their performance to be better than trained doctors in government hospitals in some cases. And thereafter, Jishnu Das, along with some other co-authors like Professor Abhijit Banerjee, etc., did a randomized controlled trial in training the quack doctors and found that training improved delivery of these village doctors who anyway used to provide medical facilities. Now, my question is, given that COVID, as you said, doesn't require extensive, complicated treatments, maybe only some oxygen cylinders and etc., how much can proper training of existing less trained doctors be a solution, particularly in COVID, but also in general for the health sector?
I mean, it's a matter of what vision, sir, you have of the health system in India. Anything in India takes time. COVID, we have to respond quickly, so we need to do what we can. I believe here you need to prescribe. For example, heparin has to be given as a medicine, prophylactic, to ensure that you do not get clots in your body. I wouldn't trust somebody who has no medical training to be conscious that heparin needs to be prescribed at the appropriate time. Also, there is a risk of multi-organ failure in COVID. So of course, oxygen is what is needed, but to identify in a specific case when oxygen is not working and you need to immediately start the movement, needs a level of training that you might have to do other mechanisms to come forward. So I don't have a straight answer as to what we can do. I believe nurses, MBBS doctors, etc. In fact, the problem with current policy strategy is not that we are working already with the existing private sector. Currently, that entire sector has been put on hold and has been told, all you can do is send patients to us. My argument is, well before we get to the untrained doctor, there are many trained doctors. Nursing homes, clinics, primary care doctors run by MBBS, run by people who do maternity, people who do all kinds of work across the entire state. Can we bring them in first? Nurses are losing their jobs. They've got not enough work to do because smaller hospitals are shutting down. Right? Can those nurses be asked to help run a housing society's oxygenation center, for example? I think there is a lot that is possible within the trained community. In the long run, one of the questions we have to ask is, are you imagining that a quack doctor will serve us for good primary care in 2040? I would submit to you that would be a very limited vision of what we want to do and what we want to end up towards in a 20-year time frame. And one of the challenges I have with this RCT methodology that you see, it is actually theory free. It doesn't have a model. And in fact, I have a problem also with, evidence, because science and scientific method goes to evidence much later, right? At the core of scientific method is conjecture, is imagination. General theory of relativity is still a theory today, right? There is data supporting it, but that came over long periods of time. So unless you have a systems design in your head and a theoretical model in your head, yes, you can certainly train some people. You know, if you see Jishnu Das's work, he will tell you markets solve the problem better. Right? So don't need to bother with state apparatus, just dismantle it. Let markets figure it out. But we know that, yes, it will be better than the current structure, but only marginally so. You will end up with the whole country having a C-section rate of 94.5% if you followed his advice. Right? But obviously, all he's presenting to you is data and interesting, signal extraction from the noise that is out there. It is our job as theorists and as policy entrepreneurs and as policy researchers to now think of a framework and a model and a design which is consistent with this data. Tomorrow, when I present to him my idea, I will have to have an answer for his finding, because he will ask me the same question, where you haven't addressed the core problem. Why will it not be the case that in 2040, when I send my standardized patient out, whatever system you have built, the doctor sitting inside the system will underperform an untrained quack. Right? Now I have to solve that problem. So, I would say, therefore, it's not my vision that quack doctors will serve us in 2040. I believe they are actually a blot on the system. They perform all kinds of unnecessary procedures. If you go, I have worked in primary care. Many of these, the mainstay of their business is third generation antibiotics, unnecessary use of morphine for pain management. I would want them to go away from the system. Right? But that does not mean that they cannot be trained. I was telling Dr. Mahadevia, one of the questions about role of gender in healthcare. The 1995 ASHA worker in Thailand is today's oncology nurse. Our ASHA of 2005 or 2002 is still an ASHA, still underpaid, still not paid. Right? You can't build her capacity like that. You cannot build a health system like that. Right? You can just, at some level, I would say it's deeply exploitative. Right, of calling somebody a volunteer, when in fact she's doing this job, for at least half her time, if not all her time. So I think there are solutions there to using the capabilities that we have, because ultimately healthcare is about training. It is not a gift from God, but we have to then train. We have to then pay people. We have to give them reasonable working hours. So a lot of those things need to happen. To me, that's a more feasible direction, doable direction, than going out there and training quack doctors.
We might test the patience of our speakers and our attendees for another 2 or 3 minutes, because there are many questions, most appropriately and coherently worded by Professor Sonal Yadav, bringing together the issues of C-section that you've been raising, Dr. Moore, and ASHA that you have mentioned a few times. They are asking, like Dr. Sonal Yadav and others are asking, what is your opinion about ASHA workers and their role in reducing the number of C-sections? Why would that not work?
The reality is that C-section is a necessary surgery. Right? In fact, there was a very large trial. I used to be the local director, India director of the Gates Foundation, that Gates Foundation had funded to try and understand, not ASHA workers, they do not have the skills necessary to even do a normal vaginal delivery, but we do have another group called the auxiliary nurse midwife, who's ASHA plus 1 year of training in delivery of babies. So she is the principal person. Almost 60% of Indian babies are delivered by such workers. Our attempt was to try and understand, can a better job of training these people reduce maternal mortality using Professor Gavande's famous checklist approach. It was, if I may, not mince words, a spectacular failure. It produced no impact on either mortality or morbidity. And again, this New England Journal of Medicine that I mentioned to you, they wrote a scathing editorial saying that, almost saying that, who allows you to run health systems like this, in which you have no surgical capacity, you have no district of Shravasti. The government is able to provide C-section to 0.4% of deliveries. Even the conservative WHO norm is 10% of medically necessary deliveries. So clearly, if you are saying the ASHA will solve the C-section problem, I'm not entirely sure of that. There is indeed one issue though, which is that if you, and this is part of a longer conversation around C-sections, that if the only people that you have that are going to deliver babies are going to be obstetricians and gynecologists, which is what you see in Telangana and Kerala, there is, and this is hard for people to acknowledge, there is a loss of skill on their part of how to do a normal delivery for a complex presentation. They are much more used to doing a C-section. Whereas if you look at the work of Professor Margaret Crook, she will argue that if you build midwife-driven centers that are in proximity to the major hospital, 30 minutes at most, right? And large delivery centers, not chota ones where one delivery is done a month, because then you can't build the skill. You will get the best of both worlds. You will get much more normal deliveries because, I would encourage you, there's a lovely British show that is based on the experience of the midwife in Britain of the 1940s. Our health system is comparable to the 1940s British health system. Right? That show is called Call the Midwife. They have a nice episode in which they show you how a midwife delivers. You have to have a strong stomach to watch those shows. Delivers a breech baby by vaginal delivery and not a C-section. Right? But it needs skill. Midwives have it. And you can benefit from that. So I wouldn't quite say ASHA, but I think a new construction is definitely possible.
Okay. All right. Two last things. One is if in this discussion, Dr. Moore or Professor Mahadevia, if you have noticed any questions in the chat box which you are dying to answer, please answer. Otherwise, these questions will be circulated later. So if there's any major question we missed, please feel free to pick it up directly on your own. Second,
so may I say something?
Yes, yeah.
I'm eager to hear later on, not right now, from researchers and academics at your end, and I would encourage them to write to me or to write to one of you if they are interested in these questions that I have raised.
Yes.
As a research project, as a long-term engagement, I'm ideally interested in PhD students because they would be looking for topics, they'd be looking for things to do, and there are many unanswered questions that need good, clean thinking to be applied. And I feel your university is well placed, particularly your business school, is well placed to answer these questions. So anyway, that's just a request from me.
Yes, perfectly. Yeah, that is exactly the purpose of this conversation series, because this an hour and a half is just a conversation starter. It's not the end of the conversation. So yes, our researchers, our students, our faculty will certainly continue the conversation with you offline. And related to that, the last comment I was making was a few people have been asking both of you to advise them on some good reading where they can educate themselves on this topic. In response to that, my colleague, Professor Sudhir Pandey, has already placed in the chat box a link to your paper, Dr. Moore, which you shared with us on consumer choice and services marketing research in the context of primary healthcare. That link is there. But other than that, any books or other academic material you think our attendees will benefit from to understand this whole area of health services delivery?
The one thing I will say is that in that link, if you go to the references section, because I'm very much a student like you, or like the people who are asking the question, and I'm assembling a lot of research. In fact, you won't find a lot of original thinking on those papers. The papers are, what you might call more accurate literature surveys and attempts at making sense of the literature rather than any original thinking. So there is an extensive reading list there. And if you look at I'm working on a book overall in terms of new health system design strategy, and the link is a part of that. You'll see if you go to the end, I think there are almost 15 pages of references. There are over 500 papers, books that I have read just in the space of last 1 year that speak on this issue. So I would say rather than me give you a random idea, that list could be a good starting point.
Okay, Professor Mahadevia, anything from you on?
No, I'm this case trying to track the literature on pandemics in history. And there's quite some material that is available. I don't often remember, I've not been able to purchase those books, but we have some very, very good literature now available. And it's now come in the public domain because there's some discussion going on about how the influence of 1918 was addressed, what was done with bubonic plague in many cities and so on. So there is now a lot of historical material available, which is really fascinating to read. And I think I would, even if you search on the Google, you would get that. I'm myself looking for some of those materials at the moment. Otherwise, there have been quite a bit of literature on healthcare delivery systems, public health, role of state and private sector. It's a long time back when I did the Gujarat Human Development Report. If you open up that, or there is a paper in EPW on healthcare in Gujarat. At the end of it, as Dr. Moore said, there's a lot of references which is there, which one could then start from there and then follow it up.
Okay, sure. We will do that, and we'll share some of these. In addition to the chat here, we'll share some of these over email with the attendees who had registered with us, and we'll get back to them with these links. So I think I doubt we can hold you longer than this. You've been very patient, and so with that, thank you. Firstly, to our two eminent scholars and speakers, Dr. Moore and Professor Mahadevia. This was so fascinating. As I said earlier, we could have let you go on with it and not interrupted you at the 5 o'clock mark, but this is a starter. This is not the end of the conversation. Between the two of you, I'm sure you'll have a lot to talk about between Dr. Moore and Professor Mahadevia. And all of us researchers and the students will stay in touch with you and come back to you with offline on what things we can do together. And of course, thank you so much to our audience who have patiently stayed here and, more importantly, furiously typed dozens of questions. We will get to all questions in due course. You will get response to questions over the next few days. With that, thank you very much and have a good evening and stay safe.
Thank you very much, Professor.
Thank you very much for organizing this, and Dr. Moore, to you.
If there is an interest, I'm happy to do another session with a smaller group of people that are interested in these questions so that we can go deeper. You know, this was a broader audience and we can schedule another, maybe a smaller call with just—
Perfect. Sure. Let's do that. Certainly.
Thank you very much.
Thank you and have a good evening. Bye-bye.
Bye-bye.